Mineral Nutrition Part 2. We'll begin our second presentation by the discussion of the types of mineral formulas. Generally, they fall into three different categories, even though there are hundreds of different types of available formulas to choose from. Standard polymeric formulas may vary in water content. They may come with or without extra fiber, and they are needed in varying amounts to provide the RDA for most nutrients. Protein is typically soy or egg white or casein. Subcategories of standard polymeric formulas are based on calories per milliliter. The standard formula generally will have 1 calorie per meal and be about 85% water. However, there are 1.2 and 1.5 and even 2.0 calories per meal, which give us 70% water. Higher calorie formulas require that extra water be given, even though all patients will need extra water regardless of the type of standard formula that's selected. Indications for standard formulas are for patients with fluid intolerance who need extra calories for these high calorie dense formulas. Examples would be someone with congestive heart failure or kidney failure. Some standard formulas contain extra fiber to help with constipation or diarrhea, depending on the type of fiber added. Most causes of diarrhea, however, are not related to the formula. They're actually related to medications and infections. Fiber formulas, however, will increase the transit time through the gut and may be a concern in patients at risk for aspiration. These patients will require extra water. High fiber formulas may also interfere with medication absorption. They may be contraindicated in patients who have gastroparesis. It's important that if a patient is to be weaned from a high fiber formula, that is done slowly, because abrupt discontinuance can lead to stomach pain. The second category of mineral formulas are elemental, also known as monomeric. These are partially hydrolyzed, meaning they've been broken down a bit. They're elemental. Rather than intact proteins, carbohydrates, and fats, they're broken down into, say, di or tripeptides, small sugars, and small fatty acids. They're basically pre-digested and hydrolyzed into their intermediate components. Indications for use of elemental formulas are for those with gastrointestinal dysfunction, such as Crohn's, cystic fibrosis, or pancreatitis, or perhaps a patient needs bowel rest. There's no evidence that these increase diarrhea, even though they have a fairly high osmolarity. Examples of elemental formulas are Peptamen, Optimental, Alitrac, Vivanex, and Vital. The third category is specialized. These formulas are available for various pathologies, such as renal, cardiac, pulmonary, liver, etc. A standard formula will provide the normal fluid needs of patients, 1 ml per calorie. Unless contraindicated, however, all patients will need some additional water. A standard formula provides 1,700 ml per 2,000 ml of formula. That's 300 ml of solutes. The patient receiving 2,000 ml of formula will need an extra 300 ml of water. This is easily given by standard tube flushing before and after meds and formula delivery and tube feeding changes. Concentrated formulas and fiber-containing tubes may clog the tube, cause diarrhea, delay gastric emptying, and dehydrate the patient. Pediatric tube feeding is a totally different animal with particular products to address needs of children. Children are not little adults. Infant formulas that have to be delivered by tube are complete. No additional water should be given. Excess water could actually increase the risk of hyponatremia in infants. It's very important to make sure that reconstituted formulas are mixed correctly to prevent renal overload. Oral versions of formulas are not suitable for tube feeding. In other words, a person shouldn't go to Walmart, buy a can of Pediatric, and put it in a tube feeding. There are also numerous specialty pediatric formula products that are available. An infant who needs extra calories but can't tolerate the volume can be given 24 calorie per ounce rather than the standard 20 calorie per ounce. There are also directions for mixing formulas so that it is more concentrated without having to buy the formulas already concentrated. So here's some examples of standard polymeric formulas, elemental and specialized. And here are examples of common pediatric formulas that are used. Due to the vast array of formulas and formula companies, and since most companies have the same type of product, most facilities will follow a formulary that they can use to guide formula selection and reduce all the inventory that could happen with different doctors prescribing different formulas. We'll now discuss formulas for specific diseases or conditions. In renal patients not undergoing dialysis, a calorie-dense, low-protein, low potassium, low magnesium, and low phosphorus formula is needed. Renal formulas are concentrated as most patients will have a fluid restriction. Standard calorie products are appropriate for patients who are on dialysis. Renal formulas are not appropriate for patients undergoing continuous dialysis as their protein and fluid needs are much higher. It will be important to monitor potassium, phosphorus, and magnesium in these patients. There are also products for patients who have liver failure. Standard products can be used unless they are found to precipitate hepatic encephalopathy. With an elevated blood urea nitrogen and consequent neurological impairment risk, we would switch to a formulation that is high in branched-chain amino acids and low in aromatic amino acids. Generally, hepatic formulas are a 70-30 combo. These formulas are also low in sodium. However, sodium levels should be routinely checked. Routine use of hepatic formulas in liver disease is not proven effective. They should only be used when other methods to reduce hepatic encephalopathy have not worked, for example, giving a patient lactulose. Hepatic formulas are lower in total calories and protein. There are also diabetic formulations. These are suggested when tighter blood glucose control is needed to reduce infections and other complications of poor blood sugar control. The carbohydrate content of these formulas tend to have a lower glycemic index. Cornstarch, fructose, and fiber, water and water-insoluble fiber types are considered. Studies haven't shown benefit across all diabetic patients, but for those who have poor blood glucose control needing a tube feeding, these formulas may offer an advantage. With lower carbohydrate percentage and not wanting to increase protein because of long-term kidney problems associated with diabetes, these formulas are a little higher in fat and may decrease gastric emptying. This is another reason why the blood glucose levels may rise more slowly on these diabetic formulas. However, aspiration could be a risk with higher fat, and so a pro-motility agent might be needed. There are also specialty formulas for patients with congestive heart failure and COPD. These formulas are almost 50% fat. The idea is that lower carbohydrate mixtures can reduce respiratory quotient, resulting in lower CO2 production and help to wean patients from the ventilator or decrease their overall oxygen needs. Some studies have shown benefit and others do not. Especially in ambulatory patients who have COPD, these high-fat formulas may actually provide some benefit. It is possible that the overall higher calorie intake is more of a problem with high CO2 than the composition of the formula in vent patients. The bottom line is, for a ventilated patient, if you want to use a specialty formula, watch that respiratory quotient. An RQ exceeding 1 indicates overfeeding. An RQ less than 1 indicates underfeeding. Both conditions can prevent weaning from the vent. We want the RQ to be 1.0 as much as possible. And sometimes high-fat formulas can help to achieve that. Because these formulas are high in fat, this can result in a slow gastric emptying rate, so aspiration can be a risk. Promotility agents may be needed, particularly for ventilated patients. Acute respiratory distress syndrome, or ARDS, is characterized by an increase in inflammation. A formula that contains anti-inflammatory nutrients such as linolenic and eicosapentaenoic acids decrease inflammation. In a few studies, specialty formulas for ARDS in vent patients has reduced length of stay and complications. These may prove of great benefit, and more studies are being done. The drawbacks are similar to others. They tend to be higher in fat. Thus, they have delayed gastric emptying, and aspiration can be a problem, something we wouldn't want in an ARDS patient. There's much interest in immune-enhancing formulas to promote wound healing and fight infection. By offering the body specific nutrients such as arginine, omega-3 fatty acids, and nucleotides, the immune system could be boosted. However, studies are mixed, and these formulations should be used on a case-by-case basis. For example, immune-enhanced formulas are associated with increased mortality in patients with septic shock, but they've been shown to benefit patients with blunt trauma, acute lung injury, ARDS, and malnourished patients who have to have surgery on the GI tract. There are algorithms and decision trees that can help guide the practitioner on selection for appropriate patients. Immune-enhanced formulas are expensive, but if they reduce length of stay in the ICU, they are certainly cost-effective. Judicial use is critical. More definitive studies are needed prior to recommendation of routine use of these formulas. We need to know which patients and conditions that they're most effective. Let's also look at basic and modular additives. As I said earlier, most of the carbohydrate provided by tube feeding formulas are from corn, usually corn starch. Sometimes they're hydrolyzed. Other times they're corn syrup solids. Some specialty formulas contain varying amounts of fiber, fructose, and fructooligosaccharides. FOS has been used to preserve the intestinal microflora, but more research is needed to determine if these can actually prevent diarrhea. Soluble fiber has been added to formulas to increase viscosity and treat diarrhea. It's typically guar gum, oat fiber, and pectin. However, this can interfere with medications and slow gastric time and clog the tube. Insoluble fiber has been added to treat constipation, but again, it can clog the tube, affect medication absorption, and transit time through the gut. If a patient demonstrates impaired gastric emptying, A patient should not be fed fiber-containing formula. Let's look at the fat content of formulas. Corn and soybean oil is the most common lipid. This is important if you're looking at a patient who has allergies to different types of proteins, oils, or carbs. Other lipids include safflower, canola, and fish oil. Fat content can range anywhere from less than 10 to more than 50%, depending on the type of formula that's selected. MCT oil is needed for patients who have impaired fat digestion, such as pancreatitis, liver failure, or cystic fibrosis. MCT is digested and absorbed without stimulating the pancreas. Note that MCT does not provide essential fatty acids. They will need to be added. Some formulas actually contain additional omega-3 fatty acids, as we talked about in ARDS and acute lung injury. Arginine is a conditionally essential amino acid with immune-enhancing properties. Studies have found that it is beneficial in wound healing. Sometimes it's given as a separate modular product. The use of arginine to modulate immune response in wound healing shows promise. More research is needed on the exact amount, timing, and dosage. Some formulas contain extra glutamine, and glutamine has also been given as a modular product. It helps to promote rapidly dividing cells that are needed in wound healing or to fight infection. During stress and injury, metabolic demands of glutamine can exceed the capacity of muscle to release it to the system. It's a non-essential amino acid unless a person's in stress. It is shown to improve gut integrity during high-dose methotrexate chemotherapy. The optimal amount and form of glutamine is still unknown. A note about medications. The type of formula selected can affect bioavailability. Also, where the tube is placed can affect the absorption of the medication. Some medicines can occlude the tube. It's important to flush the tube with water before and after administration. Time of tube feeding or medication dose adjustment may be needed to avoid drug-nutrient interactions. A typical example is in a patient requiring tube feeding who is also on anticonvulsants. Some doctors stop the tube feeding during the administration of the anticonvulsant, and some physicians simply give a higher dose and expect that some of it will be bound to the tube feeding. Of course, you would not want to crush slow-release meds, pancreatic enzymes, enterically coated medicines, or potassium replacements. Crushed meds should be added with 30 cc's of water and flushed before and after. Feeding may need to be interrupted when giving things like Cipro, Dilantin, Levaquin, Theophylline, or Coumadin. Never add medications to a feeding. When possible, use a liquid medication. However, they may not be well tolerated due to very high osmolarity. And some contain sorbitol as a stabilizer, but this is a natural laxative. If a patient has diarrhea, constipation, or excessive residuals, it may not really be related to the formula, though many times that's the first place that healthcare providers begin to make adjustments. There are other considerations. Medications for one, infection is another. One more word regarding residuals. Residuals alone should not be used as a determinant to discontinue a tube feeding. There are other signs and symptoms of tube feeding intolerance. What does the aspirate look like? Is it undigested formula, or is it clear intestinal secretory juices? Is the abdomen soft and tender? Does the patient seem to be in distress? Is the gut functioning? Residuals of 300 or more may be okay. And that concludes Part 2 of enteral nutrition.